And welcome back. And we're coming into a really nice laboury bit now, a very midwifery bit. So welcome back from the break. And I'm very pleased to introduce Dr. Claire Feeley, who's first to speak. And she's going to be talking about how do NHS midwives facilitate women's alternative physiological births. And this is going to be a feminist narrative inquiry. And I know on Twitter, there's been a little bit of a debate about looking for feminist writers. So here's one for you. Just to reiterate, I'm just doing edited highlights from Claire and Molly's CVs because it's all online. I don't want to pinch too much time from their presentations because they've got fantastic presentations for you. Just to say that Dr. Claire Feeley is a postdoctoral researcher at University of Central Lancashire. She's also an educator. She qualified as a midwife in 2011 at Oxford Brookes University. Had a master's degree at the University of Central Lancashire in 2015, and she's worked clinically in all areas during that time. So she is good at balancing just about all those juggling balls that we do. And she's just recently passed her PhD with the University of Central Lancashire, where she collated data from NHS midwives who facilitated women's out of guidelines birth choices. So welcome, Claire. The screen is now yours.
Thank you so much. What a lovely introduction. Give me one sec. Always that little delay getting the screen up. There we go. Fantastic. Thank you so much, Sue. It's an absolute pleasure to come and talk to you about my PhD study. And this is one component, one aspect of the study, because I actually did 3 different big research questions, all with the same participants. So today it's really talking about my first publication. You can see the citation on the screen there for you. It is open access, so if anyone wants to read it, you can just Google that, and it's not behind a paywall or anything. I just need to say thank you to my wonderful supervisors, Professor Jill Thompson and Professor Sue Down at the University of Central Lancashire. So my PhD title is quite wordy, as most PhD theses are, but what do I mean by alternative physiological birth choices? Well, quite simply, I define them as ones that go outside of maternity guidelines, where women are seeking less medical care or interventions, or when women decline recommended treatment or care. And primarily that's because they're seeking a normal physiological birth. And we know why this is important, because we know from the literature and the studies, and certainly from our clinical practice, that women can sometimes feel, or often, depending on where they are, feel that their needs aren't being met and they don't want to conform to the typical care pathways. And women are looking for that much more individualized care. So I was very much interested in talking to midwives who, part of their usual practice, who are willingly facilitative. By that I mean they support women's choices and they're proactive in doing so. So in my study, I had 45 NHS midwives from across the UK. And these midwives were generally from different hospital trusts. So that makes quite a nice, diverse sample in that perspective. They were also from different practice settings, and this is very important. So this wasn't a home birth versus a hospital birth or midwives study. This looked at midwives who were maybe core in the hospital, on birth suites, delivery suites, rotational midwives, could be community midwives, core birth centres midwives, and some of them were specialist midwives, say for example mental health specialists, and some consultant midwives in there as well. And the midwives, the 45 midwives, all had different levels of experiences, and you can see here that ranged from band 5 to 8, which that was really important to capture. And I'm really glad those midwives, particularly those with less experience, came forward, because I think sometimes this area, this part of midwifery practice can be seen as a senior midwife's job, role. There can be a lot of fear around it for midwives who are on the ground. So to have midwives in band 5 and band 6s, majority of the midwives were band 6. And obviously with the band, you can also, I can also tell you that some of the midwives had less than 2 years experience, and all the way up to over 35 years. So what a wonderful diverse sample set, which really helped strengthen the findings. You will be interested to know what the women's choices were. So one of the things I was very purposeful on, I could have done research on how to look after women who decline vaginal examinations, or I could have done it on women with raised BMIs or women wanting VBAC. And I could have done, you can do them as standalone research, and that in itself is very valuable. But one of my key interests and focuses was, no matter which woman is in front of you, what her choices are, what her circumstances are, this is really about getting to, you know, the pinnacle that we're after is individualized care. So I wanted to capture from midwives any out of guideline choice. So what I did find, so there's hundreds of stories within the 45 midwives, as I'm sure you can imagine. But what I did find was that they generally broke into two kind of groups. One group was women's choices who were otherwise healthy, low risk, and I will do that in inverted commas. They weren't expected to have any, you know, particular health issues in pregnancy, but perhaps when it came to thinking about birth, they wished to decline usual care pathways or recommendations. So a common one would be declining post-dates induction, or it could have been declining vaginal examinations in labour, or something like declining intrapartum antibiotics, say because she schrommmed. Then the other group, if you like, are women with slightly more complex pregnancies or complicated pregnancies. This could be because of a pre-existing medical disorder. It could have been because of their previous obstetric history. And from those women, the midwives looked after a huge range of women with multiple, and you can see that in this word cloud here. So anything from supporting women, and sorry, what I meant to say is those women with the complex pregnancies, they were actually after the midwifery-led care. So that might have been either at home, birth centre, or coming into hospital, but they didn't necessarily want things like continuous electronic monitoring. So that were for women who wanted a VBAC. The midwives looked after women after VBAC after 2 cesareans, 3 cesareans, women who had medical disorders like epilepsy, HIV, women who had previous PPHs, etc. So you get the point, and you can see that from the word cloud. So, but what I want to do, I didn't even want to separate those particular choices, because again, what I wanted to think about is what can we learn from all of that information of how do we approach caring for any woman that comes into our care, regardless of the actual choice she's making. So as you can see here, the boxes, the coloured boxes, are the key themes from this first part of the study. And then the bullet points are the sub-themes. So if you decide to read my paper, you'll get a lot more detail, a lot more information, and a lot more of the quotes from the participant. But I think what I really wanted to emphasise today was the relationship building. That will be no surprise to anyone that's watching this. Relationships, we know, is the cornerstone, the fundamental part of the care that we give. But I think what was so fascinating and useful is how the midwives in my study managed to unpack what that actually means, and in the context of outer guidelines. So one of the key messages, one of the things they really wanted to express to me was this idea of they were actively choosing to get to know the woman, as an individual. You know, they wanted to know who she was. And with that, they wanted to know all about, you know, her decision makings, her choices, her feelings, what happened in the last birth. So that was really kind of captured as this listening to understand. But the midwives really wanted to emphasize this idea that, and one of them said to me, you know, it's about listening, but not just listening, hearing, really hearing. Do you know what I mean? And that was one of the quotes. And that indicated, and that came through, that the midwives were trying to forge a connection with the women. They really wanted to get to know and understand them. And when that happened, when they did find that connection, the women's stories utterly moved the midwives. It compelled them to act. So what I mean by that, some of the midwives were so moved, it was literally, even though some of them might have worked in less supportive work environments, it was almost this sense of them rolling up their sleeves and going, right, I'm going to do everything in my power to make sure I can make this the best birth that you want. So that was incredibly powerful and a very strong message. Another factor which all interrelates is this idea of conveying attitudes of support. The midwives were there's several strands here. The midwives were very mindful that some of the women might have come in quite guarded or defensive because they were expecting to face barriers. So the midwives were very keen to remove those barriers straight away. So they've talked about having this attitude of, how can I help you? As opposed to sometimes what we see in practice or hear in practice is, we don't do that here. This kind of closed off conversation, or it's not in the guidelines, and that just shuts the conversation down and it fractures any semblance of a relationship. These midwives did the opposite. They had this attitude of never saying no, is what came through time and time again. Now, that's not to say that they didn't do any other work around that and any more conversations. As you can see in the process of support here about negotiation, care planning, etc., the midwives were particularly conscientious. But in terms of that initial meeting and early relationship building, it was around genuinely, authentically demonstrating that they supported the woman's decision, whatever that was. Within that, there were midwives who worked in fragmented care models. So they talked about how important this was too. But obviously they had less time. They didn't necessarily know the woman. They arrive at a home birth. They've never met the woman before. The woman's having something outside of the guidelines. And the midwives worked doubly hard, if you like, because they didn't have much time to really convey these attitudes of support. And one of the key things they did is sit and read the birth plan and acknowledge the birth plan and talk to the woman about her birth plan. And as many of you know, that's birth plans can come under fire quite a lot and a huge amount of criticism. But the midwives use that as a tacit way of reaching out to the women, saying, I'm here to support you. Within all of that, and underlying that was about forging trusting relationships. I say, and from the midwives' data, that trust is the glue that holds relationships together. And we know that in our everyday lives. We know that that happens in all relationships. But we don't, it's very intuitive sometimes, and it's quite hard to articulate. But these midwives did manage to articulate it. And they were very much of the mind that they knew they had not to be deemed trustworthy by the women, they had to authentically be trustworthy. So they did that in these ways that I've talked about, really listening to understand, actively conveying support. And that also might have been, if they said, oh, I don't know about that, I'll come back to you next week, they followed through. So all these little areas, these micro interactions were there to build trust. The midwives acknowledged that, particularly say for home birth situations, that the women may have experienced or heard that us midwives can find any excuse to send someone in. And we know that does happen. The midwives were very mindful of that. So they worked really hard to demonstrate that they were pro their decision, skilled and competent in home births, and loved home births. And the reason, one of the fundamental reasons around why trust is so important is because the midwives were considering that should any deviations of the normal start arising that they couldn't manage within the clinical context, should emergencies suddenly happen, they really wanted the women to understand that what they were telling them was the truth. And I think that is super important. Equally, and I don't think the literature has really covered this, is that the trust was also a reciprocal, mutual trust. The midwives, through all of this process of relationship building, forging that connection, forging that intimacy, because by now there's this intimate connection and relationship. What the midwives expressed was their trust in the women. And I really don't think we talk about that very much, about it coming from, what midwives need in order to support women, well, in a whole range of contexts. And these midwives talked very much about how they trusted the women. In turn, that gave them even more confidence to support the woman. So you get this amazing virtuous cycle, which is underpinned by meaningful, authentic relationships, which I'm sure is no surprise to any of you. But I really valued that the midwives were able to articulate and unpack that for the rest of us. Another key area from the midwives was this process of support. So they did do a lot of work, but one of the key attributes I discovered with them was their information seeking and then sharing activities. And by that, what I mean is they didn't just rely on their local guidelines. These midwives were incredibly proactive in sourcing information from a variety of spaces. So it might have been RCOG, it might have been the WHO, it might have been NICE guidelines. It might have been they knew their local guidelines was restrictive on something, for example, GBS and water birth. So they would try and contact colleagues, in a different trust with their guidelines and say, right, can I borrow your guidelines? And then take them to management or whoever they need to take to advocate for that woman. So this information seeking really spanned a lot of different sources and different methods and different ways of doing it. But it also involved knowing and having the skills to access research. And not only they knew how to access and find reliable sources of information, but they generally did understand it. And by that, I mean they could read it, synthesize it, and apply it to the woman's situation. Some of them remarks that they stood out within their kind of colleague setting, if you like, and it felt like it was a skill that wasn't always deployed by some other midwives. So a lot of time was spent talking about that. And with that information, they brought it back to the women, if they didn't already know it. So I'm also talking about situations perhaps that they wouldn't have seen very often. So one of the midwives cared for a woman wanting a home birth, but she had epilepsy. The midwife supported her right from the off and said, yeah, I would like to just go look into it, because I haven't looked after anyone with epilepsy for many years. So with that, she went off and learned all about it, learned about the risk factors during intrapartum care. But and like I said earlier, she followed through. She brought that information back to the woman in a different appointment, and then they discussed it together. And then they co-created the care plan for birth. And she had a lovely, successful home birth, I'm sure you'd like to know. So a lot of these activities, it might be the midwife going off and doing something separate to the woman. They might be doing something together, or the woman, particularly if it was a more rare disorder, the woman would, if she's lived with it her whole life, she would bring the information. If she's got her lived experience. So the midwives were open to learning in lots of different ways. And that sometimes included negotiating with women. If for some of the midwives, they did work in quite restrictive hospital trusts, and negotiating within the trust was slightly more complex or challenging, should I say. So sometimes there was a discussion with the women of, okay, what are your non-negotiables? What can we work with? What is your absolute flat out non-negotiables? Having discerned that, then moving forward saying, can we think about perhaps doing this? Very mindful all the time that they weren't being persuasive or manipulative, but once they built this relationship, it came across as it was something that they were doing in partnership. And of course, care planning was a massive part of this. And what was interesting is that across the 45 midwives, who had responsibility for what some areas call complex care planning varied. For midwives in caseloading models, then it was all down to them. They were equipped and had the skills to have these conversations with women, seek the appropriate information, document appropriately, and just basically get on with it. But in other areas, it was a much more structured and formalized process. It might have gone through consultant midwives, or a senior at the time might have been supervisor of midwives. So that in itself had so much data around it that will eventually be its own publication, because there was so much around the care planning. I'm mindful of time, so I just want to show you just a couple of key quotes. And obviously we've got these other themes here about behind the scenes, negotiating with the wider team. And it wasn't always so easy for some midwives in their circumstances to get the MDT involved or on board. And in other areas, it was just really quite normalized and just quite an easy process. And there was good engagement and good discussions with that wider team. You can read more of that detail in the paper. So this is to convey this attitude of support is was a quote from one of the midwives: "You have to go with what people want. You'll get more out of people if you say, yes, I'll support you in that, but here you are, you're the risk," rather than say, no, you can't. That doesn't really help anybody, does it? So this is that idea of meeting the women where they are, at the same time, not being blasé, because I think sometimes there can be a bit of a perception for people who fear out of guidelines that midwives could be a bit rogue or blasé about it. But if you start by meeting the women where they are, and you're still doing, well, you're doing your job through the human rights framework, but you're also you're building that foundation in order to then do the other things that you have a professional obligation to do. So in this quote, and I talked about this non-negotiable, you know, this discussion with women about non-negotiable, and this was a situation where a woman with multiple complex needs, she had a twin pregnancy, high blood pressure and GDM, wanted a home water birth and twins. So you can imagine the initial midwife might have been a little bit alarmed by that initial conversation. But the midwife who got involved, who was a very experienced and supervisor at the time, she went and worked with the woman, and she ended up caseloading her. And what she found, and by having this conversation of, never mind all the details of the actual birth decisions, let's talk about what the non-negotiables are, and let's start from there. And what you see in this quote here, what the woman actually wanted was that everyone who came into the room to introduce themselves, no one to touch her without asking permission, and any changes to the plan explained to her first. So when we meet a woman and it looks a bit intimidating or a bit frightening, coming back to this idea of, okay, let's hold our own fear, let's just put that to one side, it's not about us, and then have this sort of conversation, because what this woman wanted is dignified, respectful care. It wasn't necessarily the ins and outs of whether she got the water or not, although those were important things, don't get me wrong, I don't want to dismiss them, but actually it was about respect and dignity. She had a previously very traumatic birth, and this is what came through. As it happened, she did go to hospital, and she laboured and birthed so quickly she didn't make for twins and didn't make it into the pool. So, you know, it was all, but really interesting that she had that trusting relationship, and really helpful that she had that trusting relationship. So I would say really listening, plus understanding, and plus proactive support equals mutual trusting relationships. That for me, I think, is the key message that the midwives would want to convey, as well as those more details around the particular scenarios and clinical situations, which I'm sure you're all very interested in, but all of that content is in the paper. And I think I've never not got over my time, so I think that's extraordinary. I must have spoken really fast. I hope you could all understand me. And there I am. If anyone would like to come and find me, you can find me on Twitter as my email address. And I will be running a 4-part webinar series in March to unpack what I've discussed, the brief themes that I've discussed today, and really use those participant quotes, dig into the clinical situations, the scenarios, exactly what the midwives did in particular situations. A great example is a midwife who was called to a home birth, but the woman did not want her to do anything. This midwife was incredibly experienced, very experienced with home birth, and she found herself, that's absolutely fine. So she sat in the living room, the woman was elsewhere, and she said it was just interesting, really, because I was just listening. I was listening to how her vocalizations changed. I was listening to the frequency of those vocalizations. So she was using all this other midwifery skills and knowledge to just be there for that woman. Now, not many midwives, I think, would be as comfortable as that, because and as it happened, the midwife was called into the birth room just before the woman did give birth, but it was pitch black dark, absolutely pitch black dark. The midwife asked to put the light on, and was told a very firm, clear no. So she didn't. The baby was had been picked up, was being cuddled, and she said at that point what she did was just listen. She could hear the baby snuffling at the breast, so that reassured her that the baby was well. She was listening to the mother's breathing sounds because it was dead quiet, and so she was trying to assess, was there an increased breathing rate to indicate perhaps increased blood loss? So these amazing skills that is built up, and tacit knowledge that is built up over time and years of experience, and so much experience in unusual circumstances, that she could bring together and stay calm. I think what was so remarkable about her story is that she just didn't seem to bat an eyelid. She was experienced enough to know that she could deal with any emergency should it arise. And that's definitely contrasted a couple of the other participants who had similar experiences, but they were anxious, and actually they were getting a lot of pressure from management. And there were quotes around, actually being with the woman wasn't that stressful, but having management ring me every 20 minutes to get an update was. So you can imagine, I'm sure you've all been there when your phone's going off at a home birth. There's nothing, I mean, I hate it. It's nothing more distracting and frustrating. And then one of the midwives was very inexperienced, so she was very anxious about what management would say and whether she would be in trouble, even though working with women outside of guidelines was what she wanted to do. It was the first time she experienced it where a woman just didn't want anything. So she really was taken aback. And that is just something you can learn over time and learn through these other midwives. So there's lots more to unpack and a lot more to share with these extraordinary stories from these midwives all over the country. And I suppose my other take-home message is what's so exciting about this work is because we hear so often about what's not going well in maternity services, what midwives aren't able to deliver. And, you know, there's many women who have been deeply hurt and traumatized, but to capture where midwives and what is possible within the NHS, I think is very exciting. And it certainly brought me a huge amount of joy doing and listening to these stories and working with those research participants. So thank you very much.
That's great, Claire. Thank you so much. I mean, I think that's really a lovely, lovely point to make, Claire, because I think we need positive stories. And I think the other thing, I suppose, what I was thinking is you were saying that the midwife was going to the pitch black. I was thinking, oh my God, if you'd had an experience of a baby with difficulty after birth, you would be terrified of that. So you'd have to be very calm and very cool to cope with that. And maybe, you know, I've set up something before with the woman. But it's a really good example of how skilled midwives can be and how you can use your other skills.
And those other senses, you know, that's what was so fascinating to me. And yeah, absolutely.
Fabulous. Well, I've had one person, Catherine Cargill. Hi, Catherine. Says, thank you. That was really helpful. Listening to the women, again, coming up. That's come through as a theme all the way through the day. And that's really listening to the woman.
Yes, thank you.
And it's fantastic. It's fantastic and very encouraging, as you were talking about the whole story. So I think we'll all look forward to hearing more on this. So you can't escape that easily. A comment, this is from Nizakorn Yawarat. And she says, in Thailand, we support the patient that she has a number in my family. So she's a member of the family. It's simple to talk and help people that you've never seen them before because it's in her natural way. And I think that's lovely too.
That's that's the essence, really.
Yeah, absolutely.
Thank you.
So thank you, Nizakorn. That's really, really helpful. And I think a kind of principle is if you treat the woman as a member of your family, your sister, you know, your treasured person, you can't go wrong really, because that's the way you can get your respect. So thank you so much That was absolutely fantastic, Claire, and I'm looking forward to hearing more. And I think it's useful for people to know that Claire's got that publication, and it's free and it's accessible. And I bet you it's fantastic to read, because if it's anything like Claire talking, it'll be very accessible and very readable. So do go out and get that.